Rural Health Manager. And I'm so excited for this next presentation for you to hear. Lori Harris, if I had to describe her, she's that guru of change. She's that guru of just thinking outside her four walls of her office and really thinking, how can I help my community as a whole? And as Becky Warrior shared with you a few minutes ago, as you all know, transportation is just a huge issue throughout all of our rural communities. So when I was on a call, gosh, I guess it was sometime last year with Lori, we meet by twice a month to chat in a committee meeting. She was sharing this new program that she was rolling out, and I was so excited to hear this and continue to listen to the success of it. So I'm so happy she was able to come today to share with you what she's developed and the success it's brought to her community. Lori is a registered nurse with a master's degree in public administration. She's also currently working on her doctorate of global public health at IU Fairbanks School of Public Health. She has worked for the state government of Kentucky in positions of healthcare reform law and health insurance regulation. She's worked at non-for-profit hospital and OB and women's health and in physician services. She's also worked for the Medicare Quality Improvement Organization and currently serves as the CEO of the Family Health Centers of Southern Indiana, which is an FQHC. As you all know, and that's a non-for-profit center, if you're not familiar with that terminology, that serves low-income, uninsured, and underinsured residents of Southern Indiana within the realms of primary care, dental, chiropractic care, case management, and support services. She's also written and been awarded over $50 million in grant awards since taking over this leadership in 2010. So at this point, Lori, I'm going to turn it over to you.
Thank you, Joyce. Good afternoon. Yeah, it's kind of interesting. We were just on a call that we're on bi-monthly, and I was just giving my update to the United States Department of Health of some of the things that we're trying here at our health center. We're not one of the largest health centers in the state of Indiana by any means, but we do serve Southern Indiana. And so, yes, I don't know if a change agent would be the way to describe me, as Joyce said, but I just try different things, right? If it works, it works. If not, then, you know, we'll try something new, right? Always looking at ways to serve our patients better and meet their challenges and needs to get them on the road to better health. And that means for a better community, the way I look at it. So we're just going to talk, you know, everyone's familiar these days with social determinants of health, and transportation is kind of the focus of this project that we had. But going back to that being a federally qualified health center, one of the things that we're required to do is there are certain requirements that we have to meet patient needs. And so transportation is built in being a part of an FQHC. So this is kind of not a new social determinant that we've thought about before, but how we're approaching it is brand new. And it's been more successful than I could have ever dreamed of. So first of all, how do we determine need, right? There's so many social determinants of health out there. And when you're looking at limited resources and limited staff and limited availability in your community organization, how do you determine what's on fire? What's the priority, right? We would love to be able to do everything for everybody, but we just can't. I mean, that's just practicality. So we've used some things like patient satisfaction surveys, community needs assessment. We use patient encounter forms, post-visit reports, kind of on-the-spot satisfaction. We routinely ask our front office staff, our case managers, and then feedback from our partners. And for about 5 or 6 years, we really noticed that on our these various forms of input to assess need, you know, transportation wasn't at the very top, but it was there, and the needle just didn't seem to be moving at all. So we did some things internally to try to address the transportation. And these are separate from the program I'll talk about in a minute. So these are things we had already come up with on our own to address transportation. Now, some of the larger health centers in the United States, they offer like their own van service. So we had looked into that, but because of staffing, the distance. I mean, we cover 3 counties. In the urban area, it might work, but in our rural areas, that's pretty spread out to try to have a van. There's pros and cons to that, so we didn't go that route. So what we started doing is having bus tickets. TARC, which is Transit Authority of River City from Louisville, they do have some routes in southern Indiana. So we noticed at some of our rural locations that the stops were several blocks away from where our patients needed to get to. So we called them and we just said, hey, how do you add a bus stop? How do you request that? And so we told them our needs, and they were very gracious and just moved one of the bus stops 2 blocks from our Clark location, and then right in front of our Floyd location. Harrison, they do, there's some in Charlestown, they do have a stop that goes out to the Amazon warehouse out there. So that helped too. So just talking and getting that communication open, it may not be there, but sometimes people are willing to listen. So we provided TART tickets, bus tickets then to our patients that needed it. So that worked. One other project we tried gas cards. We were trying to get more women in for mammography and breast exams. So we did a local fundraiser, raised a couple $100 and just bought gas cards. Because sometimes our patients would say, hey, I can get a ride with my neighbor if I give them gas money. Or I can get a ride with so-and-so if I give them gas money. So we tried gas cards. We only did this a couple times because actually this is no good deed goes unpunished, right? So you think that we were doing a service and we were giving out these gas cards so people could get to their appointments. But I had some of the agencies come to me and say that we work with say, hey, can you not do the gas cards anymore? Because what's happening is some of the patients are selling those for like drugs and things like that, alcohol. So don't do the gas cards anymore. So we're like, okay, oops, our bad, sorry. So that was a lesson that we tried and didn't work, right? We also contract with Lifespan Resources. In our area, that can be, and I know across the state, that can be like your Meals on Wheels agency, local area council on agency. Some of those resources, partners in the community. So what we started to do is we made a contract with them, and they serve several counties in our area. So they were able to open up transportation then for counties that we don't even have health centers in, because we get patients from those counties, but we're not even thinking about transportation for the surrounding counties. So they actually help to expand our geographical reach, because with our contract with Lifespan, they were already in the area. And so they were like, sure, we can do that. So what we do is we have a contracted rate per ride, and we have to schedule that as a health center. We call them and say, hey, patient so-and-so needs a ride for her doctor's appointment. And it's been great. The only thing with that, because of their routes and van routes, we had to call about 2 weeks ahead of time for an appointment. So if it's something that was urgent, that was a little frustrating, but overall it's been really great. They also let us put car seats in their vans, because we had the maternal child health program for Floyd and Clark County. And so the moms coming for postpartum visits, they may have had a toddler, they had the newborn, and so they couldn't get in the van without a car seat. And so we purchased car seats to put in their vans and just donated it to them. So then every age and every variety could get a ride through that. There are some local Medicaid options, not a whole lot, but there are a few, and depending on the area that you're in, that is a route that we have used as well for scheduling. Some of the other kind of unique things we've done, we've provided batteries for like electric wheelchairs, for scooters, and again, that goes back to just talking with your patient and seeing what the need really is, because we had some patients where they had a scooter that they rode all over town in little country towns, but their battery was dead and they couldn't afford the $50 or $60 battery. So again, that's like a direct purchase, which we normally don't do for patients. But again, we took up a special kind of collection fundraiser to do that. And we were able to do that. So we purchased some batteries for scooters and wheelchairs and helped some folks out like that. And it's amazing how those little things really make a huge difference in the lives of your patients. We also kind of have tried to instill in the front office staff as well a lot of training about having a no judgment environment. So I put a picture of a tractor on here because this is true story. We've had patients in our Cording clinic that they drive their tractor to the clinic for their medical appointment. And we're fine with that. We have a big parking lot. Okay, come on in. Let's, get your visit going. So again, just making sure that there's a no judgment environment, because you're not sure what that patient is facing that day or what they've gone through to get there to your service. And so we just make sure that we just welcome however they got there, right? And so just be supportive. And that's been our ongoing, what we've done for years. And we've been fairly successful with that, and we've gotten our patients where we needed to go. But there's always more you can do. So we started this project with our Metro United Way agency. Now they're based in Louisville, but they serve Southern Indiana. And there's a project they're working on with all social determinants of health. And I'm not sure how in Indiana, how far out that is rolled across Indiana yet, but it's called United Community. And they're doing a project that focuses on all social determinants of health. And it's a online referral system. So I'm able to go in there on United Community platform, and I can refer somebody for food insecurity services, for housing, for help with utilities. So it's addressing all social determinants of health. So this is a pilot project. So one leg of that was called Ride United. And this was a pilot project that they were starting, and my agency called me up and said, hey, would you guys be interested in being our guinea pigs for this? So of course I said, sure, not knowing what we were doing, but okay, just jump in. So we started in about fall of 2020, and we had a little bit of delay in getting started, because what we figured out is that because Metro United Way is based in Louisville, but we are located in Indiana, it was going through the 211 service. And I'm not sure how everyone is familiar with that, but that's a referral service for information and needs through United Way. Well, our calls were getting routed to Indianapolis. Well, this is a pilot project. And so when our calls were getting routed to Indianapolis, the United Way there was like, we have no idea what you're talking about. And so this is going on, and we were trying to figure out what was happening. And so we were able to determine, oh, it's because of our routing system, because the pilot project with Metro United Way was in Louisville. The call should have been going to Kentucky to schedule the rides, but because we were located in Indiana. So little quirky things like that, but we learned, we got it. We also worked with some local grant agencies in order to help us cover the cost of the program in conjunction with our Metro United Way pilot. We just wanted to make sure it wasn't a huge drain or cost trying this project out first. So we have some really good local partners that gave us some sort of seed money to start and get us going, in addition to the Metro United Way. So what we've happened over the past 6 months, 7 months or so, is that these are almost 15,000 unique service episodes. Now this is for all social determinants of health. That's for the whole United Social Determinants of Health project. So then we break it down by what were the services that were used. So we had 3,418 for transportation, which is 23% of that total, 6,901 for housing. And if you go on down, really the next closest was individual family support, and then benefit navigation, clothing. I lumped all those together because it was like 1%, 1%, 1%. So there you get the big idea of how many referrals we had just in about a 7-month period. So housing and transportation were the top 2 most used needs of the entire program. So that just kind of gives you a visual so we can see, okay, wow, there's housing, but transportation's right up there. And then the individual family support, requests for help with utilities and food. So it looks like as a community, we were kind of going over this, and we do have some really good food banks and food insecurity counseling and services around. So I would say a few years ago, it wouldn't have been that way. So we're happy to see our efforts take shape in a few of these, but transportation, housing and shelter are still biggies in the area. The green here is unresolved. Now, sometimes when a patient is referred to a program, it doesn't mean that we can meet that need, or their need is not exactly what fits into one of the categories. So that doesn't necessarily mean that these patients weren't served on the green part. That just kind of show you that some of those were just requested but not able to be filled simply because, for example, transportation, that's spelled wrong. There may have been something on, they were requesting something kind of crazy, like, can I get a ride to Florida to see my grandma? You know, it was just that. So those are counted even though they're not ones that we served. So the Ride United program, it's actually an agreement with Lyft, and it's a discounted rate. So the average cost per ride, we analyzed of all those 3,000 odd rides that we had, what was the average cost? So it's about $16.33 one way. And then we were looking through what were the rides used for. 98% of the rides were for medical visits. Now, the cool thing about Ride United is that you can actually refer the patient to Ride United, and they can use it for, if they're going for a job interview, they could use it to go to the pharmacy to pick up their prescriptions. They could go to a grocery store or food bank. They could go to, you know, an appointment to look at a new housing, something like that. So it's not limited as far as what the patient can use it for. There's like a whole list of things they can use it for. But 90% of what our patients used it for were for medical, which we kind of thought, but we just analyzed the data to see that. So it was being used for what we had intended it for. Some of the lessons that we did learn through the project was, again, just talking about that routing delays. So if any of you are on a border area, just be aware that if you use something like that, a larger program, that you need to find out where your call center is located and where your calls are going to be routed. The other thing that we ran into is there was a little bit of hesitancy and confusion on our patient side, because when our case managers and our front office staff were saying, yeah, because you know, you can use this for if you need to go to the pharmacy. And our patients had been so used to like our lifespan services van and our bus tickets. And you know, those are really geared towards medical only. They were like, really, I can get a ride and I can get it. Most of the time we have about a 2-day lead time versus a 2-week on our lifespan service. So they were like, really? So I can go to the pharmacy and pick up my medication, or I can go to the farmer's market and yeah, you can use it for that too. So we're still working on that, because as you see on the slide before that, the majority, 98%, was used for medical visits, but it can be used for other related social determinants of health. One thing it did help us identify is, wow, we knew housing was a need in our area, but boy, that, you know, 4,000 and some total. If you look back here on transportation versus housing. So that gives us as a community to know what exactly is being asked for. Because sometimes when you do these needs assessments and you're planning, you identify a need, but it may not be what is being requested from the patient. So this is clearly an example of transportation and housing are the top 2 things that were requested through the service. Another thing that we're doing is we're trying to use our data. So the other good thing about this project, which I really like, is that I can pull that data, I can analyze it and say, okay, 98% were used for medical visits. The average cost a ride was $16.33. Because that helps me when I go back to my funding agencies and my local grants. I can say, look, if you give us a grant for this amount, this would break down into so many rides for so many patients. And so it just helps when you have that information, those statistics, to really tell your story and make it real, because sometimes it does boil down to dollars and cents. Can we afford to do this? How many patients a year? How many rides can we provide through the service where it's practical, right? You have to look at the bottom line as well. I mean, even as nonprofits, we have to do that as well. So this just helps us to see what the cost is of the program. But the way I look at it, we were very, very grateful. Like I said, we had good partners in being the pilot for the project with Metro United Way, and then also with our local grant organization being able to support us to cover the cost of it. So this year has been great. Now the thing is, with COVID, our volume was down last year, because even though we were open as a medical facility, our volume was down just because people not wanting to come out and potentially be exposed. However, with having the ride service available, then patients that needed to come in for a critical office visit, they were able to, because it's just them in the car, them and the driver, right? Mask, it's sanitized. And so that helped. Our volume was down overall for patient volume. So it'll be interesting to see, hopefully in the next year or so, as we continue, how sustainable will the program be? Because if we get inundated with even more rides, we can handle it to a certain point, but then we'll have to start looking at, okay, where's the break-even point of, are we going to have to start limiting rides to what, are we going to have to narrow the focus down and say no only to medical visits, that sort of thing. So we're looking at that, but for right now, we haven't. Overall, my staff was really, and they were hesitant at first. They didn't understand why we were going to do this pilot project when we had these internal services we had offered, for years and had worked. And so now my staff has given me feedback. They just can't believe how many rides we shared, because when we're comparing our rides to some of the larger agencies in our area that were also part of the pilot project, we're right up there with some really large agencies. And so we are just amazed at how many people use the service and how we were able to get it off the ground and get people to where they needed to go for care. So we're really happy with how it turned out. And like I said, we're looking forward to planning and seeing what happens in the next year. So that's just kind of our ways that we've addressed it. And we are in urban and rural areas. So sometimes it is a challenge when you've got patients coming from the really far reaches of a county, even in the urban areas. So it's not really that different as far as sometimes you think people are close to things, but they're really not. So it's been a good lesson learned and to look at what our patients need and how we can meet those needs. So that's how we've done it.
Thank you, Lori. One of the questions that came through was, what are the wait times for the Lyft drivers? And are there any issues with them not having a ride maybe for their return drive back to their destination?
Yeah, the average wait time was about 15 to 20 minutes because we schedule ahead of time. Now, we did have some urgent rides. For example, we needed to get a patient in here for a lab quickly, and they were able to accommodate that within about 15 minutes. And what happens is, once the ride to the medical facility, so say they were using it for a medical visit, they were going to the hospital to get a cardiology, echo or something, not necessarily our own health center for the medical visit. Once that patient got in the car to go to the hospital, they were sent a link on their cell phone that, hey, when you're finished, hit this link and it notifies the rider to come pick you back up. So that wait time was really about the same. We only had 1 or 2 instances where it took a little longer than that, but that was the average. The average was about between 15 and 20 minutes.
Wow, that's awesome. So now that you've been doing it, the pilot project for a while and involved in transportation, my thought was, have there been other opportunities maybe that have come up that have become a little more apparent than just using Lyft or a service of that type?
Yes, we kind of used it as a comparison tool too, like I said, with our vans through the Meals on Wheels agency here locally, because with that, we had to schedule 2 weeks in advance. There was a lot of no-show because of that. With our patients, sometimes they're, on a friend's house one day and, a relative's house another day. So it's kind of hard to keep up with our patients for 2 weeks. It's a really long time. So overall, this service provided a more immediate fill to that need. For the patients that are a little less stable, this one works a little bit better than the standard, than our contract with the Meals on Wheels program.
Great, thanks. We had a question in chat. I love the innovation, test of change, and lessons learned aspects. But there is a question. Have you been able to improve quality care gap closure for these patients who are more readily able to come in for a visit?
Yes and no, because our quality programs are pretty stringent. We participate with some state learning collaboratives for quality, and also our federal grant requires certain measures that we measure on an annual basis, and it's a big report we have to do. So if the patient is willing and able to participate in their own care, and we do what we call, we have care plans that we make with every patient. So they go over and we agree to certain preventative quality measures, as well as, A1Cs if someone has diabetes, or diet and lifestyle education with some of our resources that we have. So yes and no, because it's not the transportation that's causing the non-adherence for quality measures. It's more the patient willingness. And so if I have a patient that's sort of a little bit more stubborn, so to say, that's more of a TLC with our social worker and our case managers, with our providers and our patient support staff. So I would love to say, yeah, transportation was the key, but it wasn't, not with our patients anyway. But, most of our patients are uninsured, low income. A lot of them are very transient. So it wasn't transportation. If they got here, yeah, they got their labs or they got whatever we were trying to get. But for the most part, our quality is a little different sometimes because it's more about the patient attitude and willingness. So we have to approach our quality from a care management standard of, we make, like I said, sort of the education and contract with the patient of, hey, this takes both of us. It's a team effort here. So yeah, for ours, it's a little different. So yes and no.
Perfect. Another question is, can this be used to transport a patient from our facility to their next destination, like a rehab program, if the patient has no other means of transportation?
For us, it did. So for us, we were able to, sometimes if we had a direct referral to, let's say we have some education resources in the area, like for newly diagnosed, if you have diabetes or some lifestyle and exercise changes, and that they would get in the car here and go directly to that appointment if that's how we had set it up. So for us, yes, we were. It didn't happen very often. Most of the time, the patients were just kind of like coming in for their visits or going to, like I said, the hospital for that visit or test or whatever. There weren't a lot of those kind of linked visits. I'm not sure why the patients really didn't want more of that, but we did have a few, but not very many. But they were able to do it.
Okay. A question that came to me is, Are there any considerations that you have identified in using this type of service with behavioral health patients?
Well, our behavioral health is integrated, and so we have we have telepsychiatry, and so some of our medical visits for behavioral health needs are through telepsychiatry, telemedicine, and so those patients are already at home or a facility anyway when they're seeking our care. But in-house, our patients, we did not have any issues, and if they do have an aide or a helper that they live with or that helps them on a daily basis, they were able to come in the ride too. So we really didn't have an issue with that. We treat our behavioral health just like any other patient. So if they didn't do behavioral health at home, they just got in the car and came on with their visit like normal. So.
Okay, good.
Lori, thank you for the information. Great information. But I was wondering on your transportation, if the patient or the person that needed the transportation was wheelchair bound, if you had accommodations for that.
Yeah, we do have some of our patients that are wheelchair bound. And so if we knew that when we scheduled the patient, we were aware of that. And so like if they had an electric scooter or whatever, there are certain ones that were equipped with that. Now, the thing is, what we found even better than the lift is that we could schedule for if patients had wheelchairs, but we have something called TARC 3. So our bus service, if they need an accommodation where it is right to the front door, literally door-to-door service, we are able to schedule with our TARC, which is the local bus route. It's called TARC 3. It's a special service. We can schedule that directly with them, and it's door-to-door service. And that accommodates, we've even had stretchers in that, they're stable. It's just that they're on a stretcher, or those mobile, the electric scooters, those sort of things. So no, as long as we know ahead of time. Now, if the patient, I guess if the Lyft driver showed up and there was, a wheelchair bound patient and no one had let them know, they would have to call in and get another car sent out if their car wasn't large enough. But no, we knew that going in. And so we would just let the ride know, hey, needs to be room for wheelchair or scooter, etc.
Okay, seeing some comments that this is a great service. Joyce, I
Lori-
haven't had, go ahead.
Oh, Laura, I was just going to ask if somebody wanted to start, like, try and duplicate this service, is it open? Because I know you mentioned this as a pilot, or who would they contact? What would they need to do if that's an option?
They would need to contact their local United Way representative, because I'm not sure, like I said, in Indiana, how far or it's gotten. I know there are other pilots that were for Ride United across the United States this past year, in addition to our Metro United Way here in Louisville. So they would just need to contact their local rep and see if they're a pilot city or if they can become a pilot. That's really on the United Way side to get them set up in that. And I know they are trying to roll out that United platform for social determinants of health on a larger scale pretty soon, because it's just been going like gangbusters. It's amazing how fast that service for all social determinants of health has worked out. And we're just getting to the point now we can get some information and statistics off of that. So we're really excited to see the spread of that. So yeah, absolutely.
Thank you.
Joyce, I haven't had any other questions come to me. Have you?
No, I have not.
Okay. We've heard really most of the day about how important it is to identify these social determinants of health. So Madeline, if you would want to share, Madeline's with IHA and does a lot of work in promoting identification of social determinants of health.
Hi there, Lori, thank you for sharing this great information, because I know there are several of you on this call right now that I'm working with one-on-one with your SIP program, and Z codes and uncovering these social determinants of health from the hospital side. And I know that with several of you, you've talked about transportation issues across the state and how your patients struggle to get the care that they need, or once they're discharged, their follow-up care, because they don't have the means, to get to maybe doctor's appointments, or even another consideration is even something simple as going to the pharmacy and getting their medications picked up. And so this is a great example of how the work that we do on the inpatient side in uncovering these social determinants of health with our patients, which needs to be done through screenings, we'll find out a lot of information, how we actually link with organizations such as Lori's and, the health centers and things like that. And it's even more awesome when they connect with a common electronic health record that this information could be merged. That's my big dream of reality, hopefully someday. But this is the part that I've talked about, whether you're with my SIP group or you've heard me speak at other conferences or whatever. This is what happens when we start understanding what the social needs of our patients. These are how we can go forth to grants that are put out there, and we can say, here's our data, this is what we're seeing in the place where we live, and these are the resources that we need. So please give us some money to help build them. And so this is a beautiful example of what the work, this is what it leads to. And, at the CMS Quality Conference, they actually talked about, I've been watching every day for it, and I'm thinking it's going to happen by next week, that CMS is going to put out a grant, multiple grant opportunities for people to look at using their data to build these type of programs. And what they identify as their social needs for their communities. Food insecurities is another thing. And you know what? How do people get to the grocery store to get healthy food instead of going to the village pantry and eating a hot dog on the little spinny thing? And so, there's just so much. So I think it's the wave of the future, and I think we're hearing more and more about it. And I think a lot more has been uncovered in the last year with the challenges that we have faced with the pandemic. And I think we'll see more as people really hesitated from getting good healthcare over the last year, and now they're suffering for it. But, we have the SIP project. Some of you will be hearing more about this in the HQuick project. You're going to hear more about it in the upcoming Safety Pin C work, and anything else you might imagine. It is definitely something that we all need to focus a little bit more on. So thank you, Lori. Great presentation.
No, thank you for having me. I appreciate it.
Lori, I have a question for you. You've done a great job identifying those social determinants of health, and it's not real intuitive for patients to share those kinds of concerns, not understanding that the provider can assist them with those kinds of issues. So have you employed specific processes there to make sure that those have been identified?
Absolutely. When we're saying a common EHR, that just kind of rings true to my heart, because we're actually changing our EMR this summer just to be more connected to some of these things. But that's the beauty of that, the Unite Us, that big platform, because then anybody can have their own EHR that they can tie into that, which is central. So absolutely, that's just, I had to say that. Yes, what we do is we have a screening tool that we use on all patients. And so we frame the questions, and we're very conscientious about how we ask our patients certain things, because when we always want to have a no judgment environment. So we ask those questions, and there's some good tools out there. You just kind of have to look, but like, do you feel safe at home? Do you have enough food to eat? And how you ask those questions. But I think the key thing that we've done is consistency in front desk staff. So we try to keep our front desk staff the same. So for example, the person here has done a great job. And so for one of our, well, actually 2 of our locations, it's been the same person for over 14 years at the front desk. So they know every patient by name, and they can say, oh, you got a haircut today. Oh, how's your grandkid? And so when you have that relationship, and it's all about relationship building, when they're walking down the hallway, their provider high fives them because they're like, hey, I can tell you know, I saw that you lost 5 pounds today, you know, on your check-in. Awesome job. So it's all about that relationship building, because once you establish that level of comfort, we become a safe place, and patients will tell us things that they won't tell, like a hospital social worker or something. They have that connection. And so it's been fairly easy as far as getting down to what they need and having them ask. And so we also remind our patients, we have some scripting that we do at checkout. So when we're scheduling that patient, we'll say, okay, you know, Mrs. Jones, we have you scheduled for next Tuesday. Now, do you have a ride? Do you have a ride for that visit? Are you going to go pick up your medication today? Do you need help finding a ride for that? Do you need us to schedule the home delivery service for your medication today? So we have some scripting that we also use at the checkout. So it's reminded, you know, that patient might be hesitant. They'll see the signs, you know, they're really comfortable with staff, but still they're just like, I'm not sure about that. I'm not going to ask about that. So then again, we just reinforce that at the back end when they're checking out. And then when we do call reminders, we have a call reminder service, and we even put language on there. Don't forget, if you're having trouble finding a ride, let us know. And, you know, we'll help you find a ride. So it's just, you know, we just reinforce and reinforce and reinforce after that initial screening to identify.
Lori,
Perfect.
do you find, I don't know, I'm more hospital side, not office side, so I don't know all the ins and outs, but I think it was in January that the new coding changed in the practices, the medical practices, and for how physicians, the time spent with their patients. And I know from what I've read, a portion of that is supposed to include those conversations about maybe these social determinants that are impacting their health. I mean, it could go all the way back to, you know, an adverse child event, you know, that could be impacting what they're experiencing now. But are you seeing yet with this change, if I have this right, that your providers are actually engaging in more of those social conversations with your patients?
Well, for us, it's a little different than probably a normal primary practice, because remember, we always serve the underserved. So our providers always do that anyway. We're not like set to a 15-minute segment. And we really don't get too caught up on coding and the billing side of things, because so many of our patients are uninsured. And so we pay attention to that for the little bit that are insured, but not that closely. So providers, it's just part of our nature and who we are. And so that's just ingrained in our providers to begin with. We take care of the patient and we meet their needs where they're at, the patient where they're at. So that kind of conversation, again, is part of that practice model and workflow that's already integrated in how we do things. So, you know, the coding can come and go, but how we do what we do is just kind of set up in a flow. And so it's worked in there. And so for private practices, that might be something that you look at as far as a workflow and maybe even some talking points. Because if you've got a provider that's really, you know, you've got some of those that are, I won't pick on some, but, you know, you've got some that are just more to the book, very clinically focused and don't remember. And so it's funny because when we've had those, they'll come out and the MA would be like, well, didn't you know her dog died? Or, you know, she got kicked out of her apartment, and like, no. So, you know, they've learned the lesson the hard way, because that really impacts if they're taking their medication, if they're, you know, following what they need to be following. So adherence to quality, those quality metrics. So we just incorporate it into who we are. But again, we're an FQHC, so we're a little different animal than like my private practice, right? It would be hard. Honestly, it would be hard for my primary care provider, who I've gone to for 15 years, to be like, so are you having food service? I mean, like, that would be a hard conversation for him. That's just, so I think some of that scripting again, and then just workflow outline and some just reminders, talking points to get them started and comfortable with how to even address those. And like I said, those questionnaires we use are really good for both sides, provider and patient, because the language is written in a way that's, again, non-judgmental, very easy, very conversational and focused. And so I think using some of those tools will help get them used to that, because it'll take a while. It will, if you're not used to that model of practice. And it can be done in 15 minutes, because that's what I hear from some, like my medical director. Well, we do have to see so many people a day. Yeah, you do. But if you work it in and you just make it part of the flow, you can ask those too.
Well, we're working on that right now on the hospital side, and it's really introducing, people to these different tools, and find one that fits your organization or who's going to be asking the questions, because really it's kind of all over the place right now. Is it somebody, at the registration desk? Will it be a discharge planner? Will it be a social worker? Will it be the nurse who's doing the admission assessment as well? And so a lot of learning to be done, but definitely the tool is very important. And the more you use it, the more you become comfortable with, having those, kind of like having to do motivational interviewing and all of that.
Right. And I did work on the hospital side for years. And so I kind of get both sides of the fence. I see where, if you have a good discharge planner, that can make the world of difference to that primary care provider, because the more information you give us that we can start planning and working on those problems ahead of time, it makes a world of difference. Then, oh, here you go. Here's your discharge summary. The planning, and it takes time to meet some of these needs, because sometimes you got to be creative and think and pull resources from all kinds of places. So the more lead time you can get and build those partnerships with your local hospital, between those case managers and discharge planners with your local providers, that makes a world of difference.
Mhm. Absolutely. Well, Lori, thank you so much. We really appreciate you sharing all your information today and taking time out of your busy schedule to share what you've done. So